Adam, you ready now? And those that are joining virtually, can you still hear us okay? All right. Everybody, thank you very much for your patience. We were just trying to make sure we got a few technical things straightened out before we got started so that everybody could hear and see what was taking place. And with that, we'll go ahead and get started with today's meeting of the Kentucky Opioid Abatement Advisory Commission. We're here today and want to first of all make sure we thank the University of Kentucky Center of Excellence in Rural Health for the facility that we're utilizing today and the opportunity to be here in Hazard and to be able to meet with folks and to be available. So I want to start out with that. With that, we'll start the roll call. Dr. Freeman?
Here.
Dr. Brunzel?
Present.
Mr. Weber on behalf of the Treasurer Metcalf?
Present.
Ms. Purdy?
Here.
Ms. Raines?
Here.
And with that, we have enough members for a quorum, and we'll go ahead and get started with today's meeting. First, I'd like to see if I can get a motion for the adoption of today's agenda. May I have a motion for that?
So moved.
May I have a second?
I'll second that.
There's a second. All in favor?
Aye.
Aye.
Any opposed? The motion passes. We move forward with the adoption of today's agenda. Next up is a reminder of the business meeting schedule for the upcoming meetings. Next meeting is September 9th. All of the members have had an opportunity to review the last month's meeting minutes. Seeing that they have, I'll ask for a motion being made to approve those minutes.
I make a motion to approve the minutes as read.
Dr. Brunzel, any discussion? Seeing none, all in favor?
Aye.
Any opposed? The motion passes. Next up is the Executive Director report. Just a few matters to report to the Commission and those present also with us. First on the item list is the local reporting of the use of funds. Effective July 1st, that process has begun and is available and is now an open process which the Commission is now being able to do. We will be moving forward with that, and those items can be found and updates can be found on the website. The other item which is also can be identified on our website is the Research and Innovation Grant application window is now open. That opened also on July 1st, so both of those are available and can be utilized and seen through our website. And then the last of the new items for me is new staff. We have joining our staff is Kelsey Thomas, who's going to be our engagement and advancement specialist. So she's joining the team, so we'd like to welcome Kelsey to the team. Also, we have two of our interns, Ollie Fagenbush and Ethan Skolnick, who are here as summer interns. So we want to welcome you and appreciate you here with us for this summer. With that, I want to move forward and see if there's any individuals who've requested for public comments. I have one who I've seen.
Ask for one point?
Can you hear me?
Can I ask for a point of clarification? The portal is open. When does it close on research and innovation grants?
The date for
December
19th. December 19th is when it will close.
Thank you.
You're welcome. And for the public comment sheets, I will only have one name who's requested to speak at that time.
You could ask if anybody got missed.
Lauren Carr from KYOAAC, if you please come up.
Is right here? Okay.
Yep, that'll work. Thank you. Thank you.
Gonna need this.
Yeah.
Project. Okay, I can project. Yep, that's not a problem. Can everybody hear me on Zoom? Yes, okay. Whoops, just kidding. Hold on. Hold it, okay. All right, well, I will be brief. Like Director Evans said, my name is Lauren Carr, and I'm the Opioid Settlement Advisor at KYOAAC. I just wanted to take this moment to, one, publicly thank you all for the collaboration and the local reporting tool. It's going to be really beneficial for our communities, not only to see, but also transparent and peer learning. I wanted to let you know that I've been in this role for about 16 months, and so since then we have engaged with 102 out of the 120 counties. We average about about 20 technical assistance requests a month, so there's a lot of questions. There's still a lot of room to grow. One of the things that I just wanted to say that what you will be seeing from KYOAAC as we go forward is kind of pushing towards advisory groups. We really see that the communities that are spending these funds and making change really have a local driving force, whether that be an ASAP coalition or a local health department or any kind of community coalition. People that are subject matter experts that work in this field that really know that can help and see that those gaps. We will be doing a new resource library on our website, so just please stay tuned for that. And we're also going to be utilizing the Recovery Community Centers as a roadmap for spending. So we have seen success in some counties how they have done a SWOT analysis and to see the strengths and weaknesses in their community with that Recovery Ready community certification. I believe there's about 24 counties that are certified, so we would love to see all 120 get certified. We host monthly webinars where we talk about allowable uses, but also innovative practices that are happening across the state, and that is all going to continue. There's not the big public is just a thank you for the continued collaboration, the local reporting, but I do feel that we want to make sure that not only are the counties set up for success, but also funding things that this money is intended to fund. So that is all, unless you all have any questions for me.
Thank you. Any questions from any of those of you who are online with us? Okay. Thank you.
Thank you.
We still have an opportunity, although I want to make sure if there's anybody who didn't see the sign-in sheet and is looking for an opportunity to speak to the commission, I want to make sure that you're aware the public comments are open. So we have a space available if anybody wants to take this time for any more comments. Okay. All right, just wanted to make sure. Thank you very much. With that, make sure we get this. With that, we'll go ahead and move forward into the discussion of funding priorities. The commission members should have received some information and guidelines in terms of the way we're going to look at this and starting moving forward. I'm just trying to see if I can get from those online to acknowledge with us if you've had a chance to see those and have a little bit of understanding what we're talking about. Okay, thank you. What we're going to do is work through a little bit. Again, the goal for today's conversation is to talk about priority setting for the next round of funding and what that looks like from the commission. We want to use this opportunity to have a dialogue in terms of what the commission wants to set as the next goals and priorities. As we did last year, we want to be clear to those who are going to apply, those who are going to inquire, and those who want to understand the work of the commission, what the priorities are, what we're looking to achieve, and to have some clear guidance on that. So we're going to go through and use a little bit of last year's priorities to focus and hear from you all about your thoughts on this. So what I will do is go through the last year's priorities and some of the inputs we've received this year, and then ask each of you individually if you have any comments or things you want to make sure. As you know from last year, that will allow staff to go through, compile the information in a way, and assemble it in a package which we can then come back to the commission and look for some formal decisions on priorities. That being said, I'll hop right in with last year's prevention. It's at the top of the list, and one of the things that was that we as staff and the whole team will go through and try to provide some more clarity, not just for the commission, but also for those who are applying and going through the process. So that is one of those things we want to make sure. As you'll see or have seen, there are a couple of key things which we received in our public open forums. One was school-based prevention efforts. Another was out-of-school activities, including developmental type activities, naloxone distribution, reduction of adverse childhood experiences, and also parenting education. Those are items which we have received in public input for things that people would like for the commission to consider. Dr. Freeman, I will put you on the spot and open up with you, but I'd like to first get your thoughts about where you'd like to see the commission consider for the upcoming priorities as it relates to prevention.
So thank you and good afternoon. I'm sorry that I was unable to attend in person today at Hazard. So, I mean, I clearly, I think everybody knows that I continue to really support naloxone distribution as some of the key efforts that we need to have. We've been successful in reducing overdose mortality in Kentucky, and everybody, you know, has seen those numbers. 30% drop in drug-related overdoses in the, you know, between 23 and 24. So I think making certain that we continue to prioritize naloxone distribution is going to be important for us to, you know, keep those overdose numbers down. I think from our, you know, school-based prevention, I think we've had some good things that we funded this last go round. So thinking about, you know, continuing some of that work, I also would support things in our communities. I mean, I sort of agree, you know, with the, you know, community recovery centers and things. So I don't know if we're going to have additional discussion about recovery separate, or if you want to talk about that now, Chris.
We'll do
while we're
recovery
talking
separate.
about prevention.
Yep, we're going to go prevention,
Okay.
then treatment, and then we'll go into recovery third.
Okay, so I'll stop there then and let other folks join in, and then can talk some more about my ideas about recovery when we get to that point.
Thank you. Dr. Brenzel?
No, I've always appreciated the Commission's focus on prevention. I think most of you know I'm Alan Brenzel. I serve as the Medical Director of the Department of Behavioral Health and Developmental and Intellectual Disabilities, and our department has the great privilege and responsibility to manage the federal SOR funds as well as state general fund, and then collaborate with Medicaid around focus on substance use treatment. And so it's been great to be able to coordinate with the Commission and use these funds to fund things that other sources cannot. And one of those that is difficult to fund at times is prevention. And so we in the Cabinet greatly share the focus on continuing to have prevention as a focus. I think youth focus is important, but perhaps this year maybe looking more broadly at prevention across the spectrum and across all age groups. We are having some success in decreasing, obviously, overdose deaths, and maybe some disproportionate decrease in younger folks. And so these efforts are perhaps paying off, but we do have folks across the age span where prevention efforts can pay off. I would just also encourage us to look at evidence-based prevention initiatives. That's more difficult in this space sometimes than treatment or even recovery supports, since the literature is a little more sparse and there's more variability. I think we do know some things that maybe don't work, and so making sure that we sort of use some screening around what is there evidence for this and at what level. I think prevention has been difficult in the review committee because really what we're talking about is building resilience, and resilience occurs in all forms. And so whatever we can do to support our young people and youth, as well as others of other ages, to have these pro-social opportunities. We fund heavily education-based initiatives like Sources of Strength and Too Good for Drugs, and we do believe there are evidence bases associated with that. We'd like to see more school districts adopt that, and there's not sufficient funding necessarily to support that. So I would like us to consider supporting some of those. And then I also agree with Dr. Freeman. For us, prevention is not just primary prevention, it's secondary and tertiary prevention. We consider harm reduction prevention, and so we would like to continue to focus on harm reduction. One of our major tools in harm reduction is naloxone distribution, as well as other forms of making things available to decrease the risk for those who currently have a substance use disorder from an overdose deaths. And so, and then as a pediatrician, I really do share the broad community focus around decreasing adverse childhood experiences, and now we're beginning to reframe that around promoting positive experiences as opposed to just focusing on adverse experiences. So what can we fund that builds resilience in our youth and families that decrease the risk of the development of substance use disorders. So.
Thank you. Ms. Purdy?
Hello. I concur with most of what everything was said. I don't even know if there's a possibility to do more than we're doing with harm reduction and the naloxone. We should continue that. I would like to see if there are other ways to get those numbers down. I'm not sure of that area at all, but I do think we should look at different ways to reduce deaths, if that's even a thing. I like what Dr. Brenzel said about building resilience. I think they have proven to be the ones that work. And I think we can this year continue our goals with prevention with some new ideas coming across in front of the commission. So I'm all about the prevention. Would like to see us continue to lean into that and get more measurable results and outcomes, if that's possible.
Thank you. Ms. Raines?
This is an area that's near and dear to my heart, being a former teacher of middle school students. Again, I agree with naloxone and out-of-school activities. I saw, and sometimes I think that would be great to have an opportunity to have some kind of parent education without a stigma. I know there was a community that put a lot of emphasis on the students and the training, and at the end of the day they had a parent night, and out of going to 2 high schools and 2 middle schools of 1,000 students each, there was just approximately 25 parents that showed. And I think there is a stigma that goes to that meeting. You know, parents go, only reason I'm going to the meeting because I need the meeting. But if we could do some type of outreach with parents becoming aware, because in my personal experience, you think you're doing the right thing. You think you're on top of it. It would be some kind of innovative way would be great. Again, the after school, reinforcing that pro-social, that'll be important too. We have a new program as we started this year and funding through Russell Coleman's suggestion. But again, you cannot have too much education, and it would be great to have some kind of draw with a positive reinforcement there. Kids will come they'll listen for the goodies, they'll come for the activity, so I encourage more of that too, in the classrooms and out of the classrooms.
Thank you. Mr. Weber?
I would agree with what has been said here today regarding prevention. I think prevention is key. It's really getting ahead of the problem before it manifests itself later on. Something that Dr. Brenzel said struck me, and I had been thinking about this, is that we have the youth-focused prevention, but I kind of think we are at the point where prevention needs to focus to all age groups across the board. I think anytime you have engagement from the parents, you're going to have a better outcome if they are part of the team. I'll use that term moving forward. I think you're going to see a better outcome, and I think Ms. Raines points out something that is very important, and that is removing the stigma and letting these parents know there's an interest in helping you, and let's move beyond the situation. You're where you're at. You don't want to be there, but there's an effort to help you, and we move beyond the stigmatism and provide the help. I'm not sure that I know exactly how to accomplish that, but I certainly think that ought to be something that we look at and discuss moving forward. So those are my comments, and I appreciate everyone else's. They've been very spot on today.
Thank you. Debbie, I see you.
What he was talking about, we could also encourage maybe people or of the schools or parents of the schools, because you know you have your site-based and you have your, to rally together to do a positive and not as a group of trying to focus on maybe awareness for all kids, and that would be their project that they could do. Instead of parents seeking advice, parents could be trained to work with, you know, helping educate our kids, and then we're actually training the parents at the same time. That may be a suggestion, you know, more of a helping concept instead of a inquisitive concept for yourself. That's a thought.
Thank you. One of the things I'll do with each of these segments as we go through this one and the other two is, as you know, as I mentioned earlier, staff will go back through and put together recommendations and things to bring to you based on the comments from today. So what I'm going to do is also ask to make sure if there's any questions the staff has about anything that's been said, if there's anything else we need clarifying for you all before we move on. Okay. With that being said, we'll move into the next phase, which is going to be for treatment. And again, last year's Notice of Funding Opportunities Priorities indicated again that Kentucky has 70.34 treatment beds per 100,000 population in 2022, making the state with the highest rate of beds per capita in the country. One of the questions or the things that came through in public comments also was that there were a number of areas which they wanted to make sure that the commission reviewed and looked at. Those broad categories are pregnancy and parenting, co-occurring mental health disorders, what those things look like from your view. And so Dr. Freeman, so I don't make you go first each time, I'll ask Dr. Brenzel to roll and start us with the treatment section.
So I think one of the areas where Kentucky has made some of the greatest strides is in the availability of treatment. I think most of us believe that the key in this area is treatment on demand. If an individual expresses an interest, that treatment should be available at that time and not later, or not come back, or not a waiting list. And so you see the statistics mentioned here about our residential capacity. I think that's a tribute to our communities and our healthcare partners and our folks in the treatment space that we have that much bed capacity. I do worry that some of that may erode in the near future. A lot of that is dependent on Medicaid eligibility, and so we will need to keep an eye on, are we still able to offer treatment on demand and that not have insurance coverage be a barrier. I would like us to now, since we have a lot of capacity, start to look at outcomes as we make decisions on programs to fund. The legislature is requiring the cabinet to create a report card that will be presented in January to the legislature around specific outcomes using Medicaid data and other outcome data. And so I would encourage applicants to include outcomes, any known outcomes of their current programs as we make funding decisions. The other big thing that's happening in this space is the adoption of ASAM-4, which is the American Society of Addiction Medicine, and that tends to be the most widely accepted definitions of what level of treatment is an individual need through an ASAM level assessment, and then programs are measured based on what level of treatment they provide through ASAM leveling. And so I would hope we might consider having a presentation on ASAM to the commission, so that as we review programs and they specify that they're ASAM 3.1 or ASAM 3.4 or ASAM 3.6 level services. And so I think we should look to encourage applicants across the spectrum of the continuum, and that we target populations of folks who might need a variety of levels of interventions. And so I think that's my main comment around treatment is that a lot of treatment is covered by other sources, but looking for some innovations, some gaps, some areas where we can help fill in where there may be access issues. But I think we're doing well in this area. One last thing, I do hear a fair amount about issues around adolescent treatment, where there's less availability of adolescent treatment. And again, that's often not residential because most adolescents don't need to come out of their families and go away and stay in a program for 6 months, but they do need intensive services within their community. And so I think I might want us to look at adolescent treatment availability, particularly around those involved with juvenile justice as they come out of juvenile justice involvement, looking at access to adolescent treatment.
Thank you. Ms. Purdy?
Summary, I agree with most of what I should say all of it, not most, all of what Dr. Brenzel said. I would like more explanation on what treatment on demand looks like past naloxone. That would help me in decision making. And I too am concerned about the bed capacity and what we'll be able to do if Medicaid and Medicare cuts come into play, and how we as a commission would look to step in for it, support it, or what we'd be able to do as a commission. And outcomes are very, very critical to everything we do. I think a lot of times we give funds in the hope that they will address the issues, right? I think if we can get more outcomes from people, I mean, we hear all kinds of information about people don't have time, not time, but enough time has not passed to get the outcomes that we all seek. So do we as a commission need to look at what the outcome window is? Maybe the team internally, administratively, takes a look at that, but I'd like a little bit more information on what the expected. We have maybe not done as well of a job as looking at the outcomes and the results. So I would like to have us lean into that a little bit more, so, if possible. So I think that's it. But I think treatment and recovery are very important. We want to have better outcomes, better numbers, fewer deaths, fewer overdoses, of course. So looking at all of that. And then the question I want to also ask, how we dealt with the beds issue, how we dealt with housing and beds. Is this the differentiation between putting them in a temporary bed for a short period of time versus long-term recovery housing? I think are some of the things that we need to clarify going forward and what we do as a commission. So those are my questions.
Hey, Vaughn, I would just ask, can you clarify a little bit? Are you asking for people to clarify that in their application, or are you talking about the commission having a better
The
understanding?
commission. I mean, what is a realistic outcome? What are we putting in the application for outcomes? What are we saying to them when they fill it out? What do we as a commission expect for an outcome? I mean, with our medical team here on the call on the commission, what are we looking for outcomes? Is it short term? I mean, we may have to do short term outcomes. Short term, of course, is stopping the overdoses. Long term, what can we as a commission provide as long term? And that would get into your long term treatments, ongoing treatments, recovery, and housing issues. And then if we start getting into long term, we really go down the road of how much support we provide to creating the not just treated person, but whole person going down the road. What are we doing, and how long we expect these efforts to continue to prevent and treat. Does that make sense?
Yeah, I just want to make sure
it all ties to outcomes. What exact outcomes are we looking for?
Okay, thank you.
Because we all hope that the what they do works, but what are we long?
Okay.
Is that making it too complicated? But you know what I mean, results.
We understand. We'll put it in work with
Okay.
it. Okay. Thank you. Hey, Ms. Raines?
What I hear Vaughn saying is somehow they come up with a rubric to evaluate maybe your outcomes, short-term and long-term. I have mentioned this at one of our previous gatherings, that getting the opinion of success from the actual person with the substance abuse disorder, and besides a 4-question questionnaire. How are you doing this week? Are you successful? I think that we need to look at and encourage many places to come up with a better way to evaluate. And I say that because that is that helps the lasting success of sobriety. It was also mentioned, I do like that ASAM level of need. I thought that was kind of an interesting point that he brought up, because like Ron was saying, you have people that won't need services, inpatient. And if you can catch it first, early, a lot more success can be attained. One thing that was mentioned also, and boy, it touched to the heart, treatment for juveniles, because that's, as you said, there was a need for treatment. And then what happens is a lot of time it gets too bad, and then you have to do inpatient. And if we could do more, or we could see as a commission more opportunities for juvenile treatment, and that's kind of a harsh word, because it shouldn't be treatment, it should be addressing the issues and the concerns of the family and the child, pretty much, because there is something going on, but no one is on the same page. So I do like that maybe we focus a little bit more on adolescents, because right now, as we know, we have 10-year-olds that are overdosing. I mean, it's happening in Kentucky. I mean, I know that for a fact from school personnel, and that's just never too early in that case. And even with the encouragement of families speaking out about it, it's an issue that you think, well, if I don't hear about it, that I don't have to address it. And sitting down, sometimes kids don't. They're like, I know. And so we've got to see what we can do in early intervention for juveniles. So that's it.
Thank you. Mr. Weber?
I'm going to echo last year's and results that we've heard discussed today. And I'm just wondering if a structure could be established or set up that would look at models in various treatment plans out there to kind of glean the best of. I mean, obviously that would have to come from professionals and experts in the field, but looking at models and plans that work and have a proven track record of success, and then